So hello again. My name is Carla Moran, and I've already taken part in the conference, and it's been a great conference so far. So I'm very pleased to be able to talk about immune checkpoint inhibitors. I have a particular interest in these because I set up a clinic in the UK looking after patients who developed endocrine consequences from these medications. And I work in a busy oncology service, so we see quite a lot of these patients. I'm going to talk a little bit about immune therapies and how they work. I'll discuss the type, frequency, and severity of endocrine side effects that we see, a suggested way to perform our surveillance and how to treat these patients, and then how to follow them up as well. So what are immune checkpoint inhibitors? I'm sure you've all heard of them at this stage because they've really revolutionized the way we care for cancer patients. And it's estimated that up to 50% of patients with cancer in the States are eligible for one of these medications. And they have completely changed the way oncologists manage cancer. So, for example, metastatic melanoma was essentially a death sentence within months. But some patients with metastatic melanoma following these treatments can have a complete radiological response and can live for many years. So they're very exciting medications. And I think even if we're not oncology, we're very pleased to be involved in caring for patients who get a great benefit from these treatments. But they do come with side effects, and hence the talk today. So I think I'll start by talking a little bit about how they work. So essentially what these medications do is they remove the natural brake that we have in our immune system. So let's think a little bit about how T cells are activated. So an antigen-presenting cell or tumor cell, shown here in black, presents tumor antigens by the MHC proteins, and the tumor antigen then is recognized by T cell receptor. And that's the first signal for stimulation to the T cell. A second co-stimulatory signal is the interaction between CD28 on the surface of the T cell and B7 on the antigen-presenting cell. And this results in T cell activation, expansion. Following activation, the T cell expresses CTLA4 and PD1, two proteins on the cell surface. CTLA4 competes with CD28 to bind B7, and PD1 binds to its specific ligand PDL1, located on the antigen-presenting cell. And these are essentially brakes on the immune system. So they reduce T cell signaling and they suppress immune activation. They modulate the T cell response. And monoclonal antibodies have been derived, which are targeted towards PD1, CTLA4, and the PD1 ligand. And these medications are called nivolumab, pembrolizumab. CTLA4 agents are ipilimumab. And there are a number of PDL1 agents, including atezolizumab. So these medications essentially potentiate the T cell activation, and we are hence harnessing our immune system to target the tumor. But this harnessing of the immune system can result in immune-related adverse events. And every system in the body can be affected. The most commonly affected systems are the respiratory system, the skin, GI system, and rheumatology. And endocrine can also be affected. Thankfully for us, the side effects that occur in endocrinology are usually of grade 1 or grade 2. You may remember that oncologists note side effects as being between grade 1, most mild, and grade 5, most severe, meaning death. And endocrine side effects tend to be mild or moderate, so grade 1 or grade 2. So we'll talk a little bit first about the PD1 agents. So this was a nice review of the literature of all published articles identifying thyroid adverse effects following immune checkpoint inhibitor therapy that was published fairly recently. So the overall incidence is 10.8%. It's particularly common with PD1 agents, so especially pembrolizumab and nivolumab, and less common, although still quite frequent, with anti-CTLA4 agents. Combination therapy of PD-1 and CTLA-4 has a further increase in the incidence of thyroid adverse effects. So what type of thyroid dysfunction occurs? Well, that slightly depends on how the information was gathered during the study, how closely it was monitored for, and how exactly the thyroid dysfunction was classified during the study. But certainly we can say that primary hypothyroidism is the most common side effect and occurs between 5 to 10% of individuals on these medications. Hyperthyroidism and thyroiditis occurs in up to 5%, and less frequently hypophysitis and adrenal insufficiency. The most common cause of hyperthyroidism is thyroiditis in these patients. And it's possible that, in fact, what was described in some of the studies was a different time point in the same disease. In other words, a patient had an episode of thyroiditis, and depending when that diagnosis was made, the patient may have been hyperthyroid or may have been in the hypothyroid phase. If one includes subclinical thyroid disease, the frequency of thyroid dysfunction is much increased. Graves' disease has been described following these use of these agents, as has thyroid eye disease. The thyroid dysfunction tends to occur early. So patients develop hyperthyroidism on average 4 to 6 weeks after initiation, and almost all will have developed their hypothyroidism by 10 weeks. Hypothyroidism occurs later, on average 6 to 10 weeks, and a small number of people will develop it much later than that. This is a typical case of thyroiditis. So this is a man who was treated with pembrolizumab, but started off with normal thyroid function. And you can see in blue here his T4 is rising, in green his TSH is falling, so he develops subclinical hyperthyroidism. And then his TSH rises up to above 80 mu per liter. So he clearly has developed hypothyroidism and is treated with thyroxine. This is a very typical case we would see. Risk factors include the cancer type. So patients with melanoma are more likely to develop this. The type of immune checkpoint inhibitor, as I've shown you, pembrolizumab has increased frequency of thyroid dysfunction. There does not seem to be a gender predilection. And there's some question mark as to whether higher baseline TSH, positive antibodies, higher BMI may increase the risk, but it's not definitely clear as yet. So all of these patients should be screened for thyroid dysfunction. And there have been many protocols suggested by numerous authors throughout the world. And really what they all have in common is that patients have baseline TSH-T4, and then they have a TSH and T4 checked at frequent intervals early on in treatment and less frequently later on. And I don't think one needs to adhere to a particular algorithm, but I think we could look to the literature for algorithms that might suit our own particular practices, and then maybe adopt it so that it's suitable for our institution. I think the key thing is that a surveillance program is in place. This is a surveillance program that I particularly like. It was published in 2018, and this was published by the Immunotherapy Task Force collaboration. So prior to anti-PD-1 therapy, we should establish baseline TSH-T4, and then measure TSH-T4 at least monthly for 6 months, then every 3 months for the next 6 to 12 months, and then every 6 months thereafter. If one develops symptoms associated with thyroid dysfunction and or abnormal thyroid function tests, it then gives a nice algorithm of how to interpret thyroid function tests for oncologists and how to initially treat these patients. But I think for this audience, we need to know about the treatment in a little bit more detail than was provided in that protocol. So if somebody has overt hypothyroidism, meaning raised TSH, low T4, we'd of course start thyroxine, and we're monitoring their thyroid function tests every 4 to 6 weeks. These patients come in every 2 to 3 weeks, so it can be quite handy to add thyroid function tests with the various treatment cycle, because they have bloods at each time point for assessment of other side effects. I would mention that it's important to think about the possibility of adrenal insufficiency, especially if they've ever been given anti-CTLA4 agents. So you might consider checking cortisol first if you've any suspicion of adrenal insufficiency. For subclinical hypothyroidism, you could start thyroxine, or you could elect to observe, especially if the TSH is less than 10 and the patient is asymptomatic. If one is observing, I would monitor their thyroid function tests every cycle. But if treating, I'd monitor every 4 to 6 weeks. And again, just consider whether cortisol should be checked. For overt thyrotoxicosis, I give these patients beta blockers, and it's because it's most likely to be thyroiditis. So you can simply observe, give them non-steroidal anti-inflammatories. Steroids are only required if the gland is very painful. And I monitor the thyroid function tests every cycle. If there's persistent thyrotoxicosis, that would raise a suspicion for me that they may have Graves' disease or perhaps another etiology for thyrotoxicosis. So I would measure their TSH receptor antibody and do a technetium scan. Worth mentioning that I would check that they hadn't received contrast recently, because of course your technetium scan may not be helpful in that situation. Later hypothyroidism should be monitored for and treated, and it might be worth considering a trial of thyroxine later on. The literature would suggest that if these patients develop hypothyroidism, it's permanent, but I think a systemic trial of thyroxine has not been examined, so it might be worthwhile considering that at a later stage. Subclinical hyperthyroid picture, remember to measure T3 just in case T3 toxicosis, and monitor thyroid function tests every cycle, and if they become overtly hyperthyroid, I would manage as above. You may consider beta blockade in these patients. Things to consider. Are immune checkpoint inhibitor therapies contraindicated in people with pre-existing thyroid disease? The answer to that is no, it can be given, but it has been described that worsening thyroid dysfunction can occur in patients with pre-existing thyroid disease, so they still require monitoring. Do we need to stop immune checkpoint inhibitors if thyroid disease develops? And almost always the answer is no. So these patients usually have grade 1 to grade 2 side effects, and you do not need to stop the treatment. You may consider temporarily stopping if they have more severe side effects, certainly if they're hospitalized, and in the very rare occasion of severe eye disease, I would stop treatment and consider recommencement of treatment after careful discussion with colleagues. So I'll move on now to CTLA4 therapy. So these patients can develop hypophysitis. And the rate varies, but it's typically 5 to 8%. And they can also develop primary hypothyroidism. Again, the rate is approximately 5%. Less frequently thyroiditis or adrenal insufficiency. So it's really thyroiditis, so it's really hypophysitis that we're concerned about for these patients. This is an example of a patient who developed hypophysitis with ipilimumab. So this man was 77. He'd had melanoma resected, but then presented with metastases 5 years after the initial resection. He was started on ipilimumab and was unwell at 2 months. He had hyponatremia and undetectable cortisol. He had low T4, T3 with an inappropriately normal TSH. He had almost undetectable testosterone with gonadotrophins inappropriately within the normal range, low prolactin, low IGF-1, and undetectable ACTH. So he has pan-hypopituitarism. And he went on to have imaging of his pituitary, which showed an enlarged anterior pituitary gland with no suprastellar extension. And so this was consistent with hypophysitis due to ipilimumab. So patients who develop this side effect almost always have anterior pituitary dysfunction. And in the majority of patients, it will be multiple. So most patients have TSH deficiency and ACTH deficiency. They frequently have gonadotrophin deficiency, and they may also have prolactin deficiency and growth hormone deficiency. It's fair to state that more patients may have prolactin and growth hormone deficiency, but we don't necessarily look for this because we wouldn't typically give growth hormone to these patients. The recovery is variable, but TSH does seem to recover in a number of patients, but not so much ACTH, as you can see here. Presenting features are headache, fatigue, hyponatremia. no patient that I know of has been reported to present with visual field defect, which is good news. Males are at higher risk, and it is related to the ipilimumab dose, and older age group are more at risk. All of these patients should have imaging, and MRI pituitary is preferred. Most of them will have changes consistent with hypophysitis if that diagnosis is present, but it's worth remembering that the appearances do change with time and they resolve in all patients. So if you image them later on, you may have missed the typical changes of hypophysitis. The onset of hypophysitis is on average 2 to 3 months. The range is very variable, however, and patients can present with hypophysitis 18 or 19 months after treatment. The onset is earlier if they're given combined immune checkpoint inhibitor therapy. And it's worth just contrasting with the anti-PD-1 agents. The onset with hypophysitis, the onset of hypophysitis with these agents is a bit later, 3 to 5 months. So the same paper I've mentioned has a screening and management program for hypophysitis and thyroid dysfunction due to CTLA-4 therapy or combined therapy. So these patients at a minimum require baseline TSH-T4 and a 9 AM cortisol. Personally, I don't tend to measure ATCTH unless the cortisol is abnormal. I do routine TSH-T4 and 9 AM cortisol levels at least monthly for the first 6 months, every 3 months for the next 6 months, and every 6 to 12 months thereafter. If at any stage there's symptoms possibly associated with hypophysitis or thyroid dysfunction, or if there's abnormal biochemistry, again, there's a nice algorithm that oncologists can follow. But for our purposes, I've slightly expanded on that. So if one expects hyperpituitarism or hypophysitis, and this can be based either on the presentation clinically, biochemical screening, or an abnormal MRI, draw blood for anterior pituitary hormones. I perform a clinical assessment for DI, but DI has only been described in a couple of patients who've received this, one of whom had pituitary metastases. So it's really very uncommon. They're very unlikely to have DI. Perform visual fields to confrontation, and if cortisol is not clearly normal, I start hydrocortisone replacement. Image with an MRI pituitary with contrast and consider the need for formal visual fields. High dose steroids are usually not required, but if the pituitary was near or encroaching the chiasm or there were severe headaches, methylprednisolone should be used. Hormone replacement should be initiated except for growth hormone because these patients will have active malignancy. The immune checkpoint inhibitor in general can continue, and we monitor their pituitary replacement every couple of months with decreasing frequency thereafter. And I think it's reasonable to repeat the MRI pituitary if it was initially abnormal at 3 months, just making sure that the appearances have improved. So some of the questions that arise is, what should we do if hypophysitis is seen incidentally on an MRI in somebody who's undergoing ICI? So this can happen because they get a lot of cross-sectional imaging. So if that happens, I would continue the immune checkpoint inhibitor, but I would monitor their anterior pituitary profiles more frequently. Do we need to stop the immune checkpoint inhibitor if the hypophysitis develops? And the answer is almost always no. You may consider just temporarily holding treatment until replacement of hormones has been performed. And if the pituitary is causing chiasmal compression, I would stop treatment and liaise with colleagues. But as I say, that really would be exceptionally unusual. So I just want to briefly mention the less common side effects of immune checkpoint inhibitor therapy. So primary adrenal insufficiency has been described very few cases. It can happen due to either class of medication. Imaging tends to show inflammation, so this is an adrenalitis, and they can present acutely or subacutely. Some have positive 21-hydroxylase antibodies, so again, fitting with an autoimmune process. And the onset is 2.5 to 5 months or can be later. You'll find a low cortisol with elevated ACTH, and the adrenal gland should be imaged because these patients could potentially have metastatic disease. Glucocorticoids and mineralocorticoids should be used as replacement, and it's usually permanent, and they can continue the immune checkpoint inhibitors. Diabetes mellitus is also described, And it tends to be a type 1 picture. So these patients are insulinopenic. Many present in DKA. And it's most commonly associated with PD-1 agents. Many patients will have positive islet cell autoantibodies, and the average onset is 2 to 3 months. There are some susceptible HLA genotypes. There's no need to image the pancreas in these patients, and they need treatment with insulin, and it will almost certainly be permanent. And again, you can continue the immune checkpoint inhibitor. Because diabetes is quite rare in these patients, but if it occurs, it's very quick and can result in DKA. Patient education is really key. So they need to know the symptoms of diabetes mellitus and to seek urgent medical attention if they occur. So the key messages, I feel, are that it can be difficult to detect, but it's very common, so we need to screen for it. We need to liaise closely with our oncology colleagues, and we need to be available to support them and to be available for phone advice, because they are managing conditions that they've never had to manage before. So we need to provide their support for them. The CTLA4, think hypophysitis, and PD1, think thyroid dysfunction. Post CTLA4 therapy, always be a bit worried about starting thyroxine before excluding adrenal insufficiency. And do remember to image the pituitary in cases of hyperpituitarism, because I have seen cases of metastases or even incidental pituitary adenomata. The side effects usually occur within 3 months, but do be wary because they can occur at a later stage. In most cases, you can continue the immune checkpoint inhibitor therapy, and high-dose steroids are rarely required. And the good news for patients is that there is some evidence that this signals a good oncological response. And I think looking to the future, it would be helpful to have some studies that very accurately assess the types of endocrinopathy, and also to systematically look at whether recovery from endocrinopathy occurs. So I thank you very much for your attention, and I welcome any questions at the end of the session. Thank you very much.